Get started. Good morning, everyone. We're back after a brief hiatus with our weekly CMR conference series hosted at VCU. And this morning, we're very pleased to be joined by Dr. John Grizzard, who's an associate professor here at VCU School of Medicine and the section chief of non-invasive cardiac imaging within the radiology department. And he's the authority on cardiac masses, and so he's going to be presenting on the CMR assessment of cardiac masses, which is a common source of anxiety, I think, in the imaging lab across modalities. Just a reminder to everybody that these sessions are CME and MOC accredited, so don't forget to text the code on the screen to the number provided. And for MRI technologists in the audience, we've also got ASRT accreditation for today's session. So don't forget to also log your attendance. You have to be logged in individually on your Zoom login so we can sort of track attendance. That's one of the things they make us uniquely do for the ASRT. And with that, I'll turn it over to Dr. Grizzard. Thanks again.
Sure, yeah. You can hear me okay? I think it's not muted. Yeah. Okay,
yes,
good.
We can hear you great.
You may see up there on the slide a number to which you can text a string of letters. Hold on, let's see. It's also there on the at the bottom of this slide where it says text this string of letters and numbers to this number. That's an audience response enabler thing that will let you all chime in to give answers. We're going to talk about cardiac masses today, and it seems like a kind of uncommon thing, but a lot of things in MR, you add together small areas and they become substantial, sort of like pericardial disease and certain other things. And it's the most definitive test. So a lot of things that are confusing on other modalities end up coming to us. I don't have any disclosures, and we always are using gadolinium in many instances as an off-label indication. Okay, and I have a few questions, as I mentioned, so just to go through them. And let me go back and make sure you guys have a chance, if you want to sign this up. And I think Corey is going to put that in the chat as well, that text thing, so that people want to join in, they can. Okay, so this is a question that's always asked in radiology board exams, or very frequently, is the most common cardiac mass, and you see the options there. And then people can respond if it's working. I guess this will be a test case if anybody has been able to log in or wants to. We'll leave that up for just a minute. The text number you can see up at the top. Yeah, there you go. There you go. Well, we got a pretty even split between myxoma, METs, and thrombus. Very good. Okay. And when you get through this, we'll give you the answers to these. They'll become apparent. So sorry to kind of do a head fake there. This structure with the arrow pointing to it is, and here's your list of options: benign neoplasm, Thebesian valve, crista terminalis, eustachian valve. Okay, give you a chance to weigh in. You'll see later if you were correct or not. Well, people are having
Dr. Grizzard, we don't see the results. Are you seeing the poll answers?
Yeah, I see them. I think, yeah, I did see it.
But maybe you don't want us to see them, so we're not influenced by the crowd. But I don't. There might be a way to show it to the audience after everyone's logged in.
Well, yeah, and I'll just verbally tell you all that people, 100% of people put eustachian valve for this, and on the prior one it was third. And there's something about doing this in PowerPoint for Mac that is the problem here, and I'm not, I cannot remember exactly how to fix it. But having said that, I'll just verbally relay what we're seeing here. Okay.
Sure.
Regarding thrombus detection, CMR without contrast is twice as sensitive. Here are your options. Echo with contrast is just as sensitive. CMR with contrast is twice as sensitive. Transesophageal echo is more sensitive. And we give you the option. And I'll tell you what people are saying as we go along. So far, option C is receiving half the votes, and CMR without contrast at top is receiving half the votes. Okay. Now the CMR with contrast is twice as sensitive is pulling into the lead. Very good. Okay. Regarding cardiac tumors, are they more common, the primary cardiac tumors, are they more common than METs? Melanoma is the most common primary, or METs 20 to 40 times more common. Benign lesions are less common than malignant lesions. This is regarding primary cardiac tumors. Yeah, so far everybody is chimed in, is correct. And that is, well, now we've got a 50-50 split, Mets and melanoma. Okay, fair enough. So we're going to get to all the answers on this as we go along. And here we go. So here's what it's like. We have a patient presenting with a suspected cardiac mass, and we're trying to debate how to work it up. Options include echo, CT, and CMR. And, echoes has great availability. It's fairly portable. You can get very rapidly acquire images. The problem is you don't always get comprehensive 3D imaging of the cardiac structures or the mediastinum, and you don't have great soft tissue resolution in terms of characterization of tumors and so forth. CT is a little bit better in terms of being comprehensive in terms of its coverage, and it's a push button technique, which is kind of appealing. It's not quite so intensive. It's not as hard a job for them, but it doesn't have great temporal resolution. You can't really demonstrate motion very well unless you do gated techniques, in which case you're giving them a lot more radiation. But with MR, you're able to get around all those limitations. You can get unlimited multiplanar imaging with better soft tissue contrast than with CT or echo, and you can simultaneously evaluate function. You can do repetitive injections of contrast for perfusion imaging, which is really helpful in characterizing cardiac masses. It's not universally available. Pacemakers seemingly are disappearing as a contraindication. We're doing everybody with any kind of pacemaker, it seems like. Older aneurysm clips are still contraindication. Okay, so just using CMR, this is what I was referring to when I said unrestricted multiplanar imaging. You see, tumor coming up from the renal veins up into the cava, but then subsequently it's embolized to the right pulmonary artery. So this kind of global comprehensive imaging is something you can do with MR. And here's a large pericardial cyst on T1 and T2 mapping. T1 and T2 imaging demonstrates very high signal on T2 with iso-intense signal on T1. And with cine imaging, you can see the impact of whatever tumor is present upon the valves and the myocardium. So how do we do it? What's our protocols? Typically we get single shot dark and bright blood imaging in the usual cardiac imaging planes, the usual orthogonal imaging planes, axial and sagittal. You may or may not do coronals every time. It sort of depends on the orientation of the lesion, and we cover the whole chest. And what you get is a stack of these images like you see in this rapidly moving sequence. But basically, you get this whole stack in probably 30 seconds per acquisition, and another 30 seconds if you do the coronal like you see here. We then do cine SSFPs to cover the heart and the standard short and long axis, just like usual. And that's so you can see the impact of any tumor that's present upon the myocardium. And it actually helps you define boundaries and motion and so forth. I think cine imaging is very helpful. Perfusion imaging is one of the most helpful sequences to use. There's some interesting work being done by Jonathan Weinsaft and his group at Cornell Weill in New York, where they're demonstrating that perfusion imaging with MR can actually characterize the aggressivity of lesions based on their enhancement pattern. They can give prognostic information. And so you're obviously looking at lesion vascularity like you see here with this hypervascular multiple renal mets that you see both in the anterior wall and at the inferior wall. And you even see the little lung met lighting up as well. We get late gadolinium enhanced images with normal nulling of the myocardium and the usual cardiac stack, just to get this is that same renal cell Mets case, just to characterize this. Typically, Mets are often heterogeneous like you see here, and we'll also do images with a long inversion time in order to detect thrombus. We're doing these from the base to the apex. As you can see there, both the right and left ventricles have apical filling defects or thrombi. To be honest with you, although all the books are going to tell you to do T1 and T2 imaging and they'll talk about the characterization, I have a little secret for you. It's a waste. Well, I wouldn't say it's a complete and utter waste of time, but just remember, you're getting T2 information from the cine images a lot of times. It's not a perfect T2. It's kind of a hybrid T2, but you get some T2 images from that. And you get T1 data from the late gadolinium enhanced images as well as the perfusion images. So I don't always get T1 and T2s, and if I do, it's maybe just a slice or two, because the other little secret about them is that almost every tumor is isointense on T1 and bright on T2. There's a notable exception to that, and that's worth talking about. But other than that, I find it to be less helpful than you might think. There's some instances where, doing fat suppression kind of proves, like in this case of a lipomatous hypertrophy of the interradial septum, atypical, it's kind of bulging backward there. But that's very helpful to characterize things. Okay, so just think of it this way. Your standard CMS protocol is designed to answer a series of questions. Where is it? You find it based on the localizers many times. Does it impact function? That's what the CINE-MRs are for. Does it enhance like normal myocardium? Is it more or less vascular? And that's helpful with the delayed enhancement lesion sequences as well as the perfusion sequences. Is it a thrombus? Well, that's going to be, usually those long TI single shot images will help with that. And you can do other tissue characterization as needed using T1 and T2 and fat suppressed images. So ultimately, we're left with these possibilities. You get this thing, it's a known or suspected cardiac mass, might be a normal variant or a pseudotumor, we might be getting faked at, or it could be a thrombus, which is kind of a mass, but not really a neoplasm, or it could be a neoplasm. So we really just have to sort these three options, right? So here's a case study. A lady goes into the echo lab, she has chest pain. Echo shows a really big mass indenting or invading the left atrium, not clear which. The radiologists in the group here may recognize this pretty quickly. You have an axial series and then a coronal image right here where you see this large lesion protruding up from the abdomen and indenting the heart. You can kind of see it here. I'm going to go to the CINE sequences next. It's a sort of complicated or complex mass. See it indenting the left and a little bit of the right atrium and cava. And here it is here again, indenting that. And here's a delayed enhancement image of a large hiatal hernia. So this is just when the stomach pooches up through the diaphragm and can impinge on the heart. So that's what we would consider a normal variant or non-neoplastic structure. So other pseudomasses are like the eustachian valve that we showed earlier, right? This is one of our questions. It's a little flap of tissue that is seen at the junction of the IVC and the right atrium. And, it's sort of in a way to think about it is that it maybe in fetal life, it served a direct flow across the fossa ovalis, the high oxygenated blood coming up through the ductus venosus. And you want to direct that into the left atrium, bypass the lungs and have it go straight up to the head. So that might be what the function of the eustachian valve is meant to be. Crista terminalis is a normal little embryologic remnant, sometimes really prominent in some people. Particularly in the axial plane where it can mimic a little tumor like you see there. But when you lay it out in an oblique coronal plane, you can tell what it is. It's a normal ridge of tissue that is an embryologic remnant also, marking the site of fusion of the embryologically derived right atrium and the sinus venosus derived portion of the right atrium. Atypical mitral annular calcification can really be kind of a fooler. The post-contrast images here look really odd. There's also a little infarct there. Don't be fooled by that on the post-contrast images in the lateral wall. But that infarct, that atypical MAC can be confusing at times. Pericardial cysts, some people will include with pseudotumors. Other things, including like this, where you have a very prominent coronary sinus, is actually due to a dilated or persistent rather left SVC. So that's a normal variant as well. So pseudotumors kind of fall under these headings. They can be abnormal non-cardiac structures like a hiatal hernia, pericardiac cyst. It can be a normal variant, as we've talked about eustachian valve and Crista, or it can be a non-neoplastic structure like atypical MAC or a dilated coronary sinus. And you can figure them out pretty quickly with MR. It's really not a tough call, right? So let's do another case. Here's a 59-year-old lady with a suspected left atrial lesion found on echo. There does look like there's something hanging down from the atrial roof there. So that's real. It doesn't look like a fake. CINE images confirm it. You can kind of see it faintly moving around there where that arrow is. And there it is on perfusion imaging. It does not appear to show any enhancement. So it's not going to be a normal variant or pseudotumor. So we're left with these other options, right? And so these are the questions that when you're evaluating a cardiac mass, I think are very helpful to try and answer. Location, and by location, I mean, is it intracavitary, intramural, or epicardial? those things are usually going to help you limit the differential significantly. And is it invasive or not? And does it have abnormal enhancement? So what do you guys favor just on what you've seen so far on this lesion? Do you favor myxoma, thrombus, papillary fibroelastoma, or MET? And I'll tell you guys what people are saying. There's a link up at the top. You can see where you can join in if you want. And there's also a QR code thing. Oh, some people went with papillary fibroelastoma. Interesting. Yeah, it kind of could be. I mean, it's sitting right up there in the left atrium, not a bad location. We've had cases of that. Other people are going with myxoma, so that's now a 50-50 split. Okay, fair enough. So let's go through it. In terms of answering the questions, its location is intracavitary. Its tissue characteristics are that it's well-defined, it's not invasive, and it's iso-intense to muscle on SSFP. That's important, right? We're going to talk about why that's important. And it does not show enhancement. I didn't show the late gadolinium enhanced images, but it does not enhance on that. And so these are characteristic findings of a thrombus, right? And so follow-up images after 6 weeks of anticoagulation, the lesion resolved, right, proving that it was a thrombus. So thrombus is actually the most common cardiac mass. Remember, I'm not saying neoplasm, I'm saying mass, right? And their location, they're commonly along the inner margins of the dilated apices or the areas of akinesia, often seen adjacent to infarcts or lining an aneurysm, as you see here. They can be in the left atrium and left atrial appendage and so forth in people who have atrial stasis, like in this patient with amyloid. Other patients with AFib will have similar problems. I think it's important to note on its signal characteristics that it's iso-intense to muscle. That's an important point that'll help it be differentiated from other lesions, specifically myxomas and so forth, when they can sometimes be in the differential. Notice that this is that same image that I showed earlier, where you could clearly see the thrombus post-contrast. Prior to contrast, this was not detected. We knew there was something wrong with that wall. It was thick and it wasn't moving properly, but it really was a lot more apparent what it was after you gave contrast. So there it is, post-contrast. It becomes really apparent. And thrombi will obviously not take up contrast on perfusion or delayed enhancement imaging. Jonathan Wansaft, when he was at Duke, did a large study, 784 patients with reduced systolic function, and found an overall prevalence of about 7% of these people had thrombi. Interestingly, and maybe understandable once you think about it, ischemic cardiomyopathy conveyed a greater than 5-fold risk relative to non-ischemic cardiomyopathies. And if you had an area of greater than 50% transmural infarction or hyperenhancement, that was an independent risk factor. And you often notice that the thrombi were adherent to areas of infarction. So that's a good thing. You know, if you see delayed enhancement and it, you know, very bright and enhancing, be very careful to look for adjacent thrombi. So LGE imaging of thrombus is best performed with the same inversion time that we usually use for the myocardium, a shorter inversion time or a longer inversion time. Yeah, so far everybody is saying long inversion time, which is correct. Yeah, very good. Okay. A long inversion time because it selectively nulls thrombus. Let me just mention that in the older type of sequence where we did just a magnitude image, we didn't do PSIR or phase-sensitive inversion recovery, you can get a confusing appearance from thrombi. You'd sometimes see them as bright with an etched rim, and then when you did the long TI imaging, it became apparent it was thrombus, but this appearance is sort of confusing. And the reason it happens, I'm going to show you, and this is not to belabor any physics or anything, but let me just explain this, why this is bright, because it's confusing, right? On a magnitude image, when you give the inversion pulse, you flip all the spins upside down, right? And then you let go and you start imaging. And the inversion time is how long after that inversion pulse you'd start imaging. Now, if we image right here, normal myocardium has come back up and is at the zero crossing. It's no longer inverted. It's not back to positive. It's right halfway in between. And so it has no signal, and the myocardium is black. Notice the infarcts are bright because they're above this area of infarction here. But notice that thrombus is almost equally far away from the zero crossing and is therefore bright. So this sequence only knows if you're at zero or if you're away from zero. And the further you go away from zero, the brighter white you get. So thrombus is bright because it's actually below the zero crossing line. It's away from zero. If you wait an image when the thrombus crosses the zero crossing line, then it loses signal, and the infarct and the normal myocardium have recovered and are above zero crossing. So that's why we do long inversion time images, right? It's to help detect the thrombi, avascular structures. Regarding thrombus detection, we talked about this was in our opening slide, and I think everybody kind of got this. CMR with contrast is twice as sensitive as echocardiography. This was shown by Wansapt, and it's been validated by other series. But it requires contrast for that to be detected, for that accuracy. If you don't give contrast, you very similarly to echo, you only pick up about 40% of thrombi that you're going to pick up in total if you give contrast. And that's because, the thrombus is isointense to myocardium. So remember that you really, for maximum sensitivity of detection of thrombus, you really need to give contrast, okay? Very good. Vegetations, I want to just mention, they're kind of best thought of as a special case of thrombi that are attached to valves and valve apparatus. Usually this one happens to be attached to the chordae of the tricuspid valve. They're often seen in the setting of endocarditis with valve destructive lesions that result in markedly impaired valvular function. So it looks like this. You're not really debating, is that a myxoma? You're going to know that's a vegetation. Signal characteristics wise, it's very similar because actually they are sort of like a special case of thrombi, infected thrombi, right? Okay, another case study. So we have an older lady with an abnormal echo suggesting a right atrial mass, but she had a central line in, and so they were thinking maybe it was a thrombus. And here's her right atrial lesion, and I think you can see it kind of hopping and bopping there above the tricuspid valve. Notice that when we give perfusion imaging, we give contrast, it does not appear to enhance. And it has a little area of enhancement along its inferior margin. And to be honest with you, when I read this way back when, I thought, oh, that's kind of a big round thrombus coating a little bitty myxoma, right? But I was wrong. In retrospect, I should have maybe known I was wrong. Let's go through why. Its location, it's intracavitary. That helps with the differential. Tissue characteristics, yeah, it's well-defined. It's bright on cine imaging. Now, I'm going to say that again. It was bright on cine imaging. That at first didn't dawn on me the importance of that. Enhancement, yeah, it has a little bit of enhancement, but it's really not very vascular, right? It's pretty much avascular, okay? So the signal intensity is the key to the diagnosis here. And what is it? It's brighter than muscle. We've said thrombus. If this was thrombus, it would be isointense to muscle. So this is not a thrombus, right? What is it? It's going to be one of these, right? I bet everybody gets this in a heartbeat. Yeah, it's a myxoma, right? Everybody's chiming in on that. And that's exactly right. Okay, so the diagnostic possibilities in this case pretty much ruled out a normal variant. We ruled out thrombus as we described. So it's going to be a neoplasm. It's bright on SSFP. It's not isointense to muscle. So it's a myxoma, not a thrombus, right? And this takes us into the discussion of primary cardiac tumors. Benign tumors make up about 3/4 of all primary cardiac tumors, and they produce problems, from arrhythmias. They can be related to arrhythmias. They can obstruct cardiac flow. They can produce emboli. Particularly myxomas are famous for producing kind of a myxoma syndrome where they'll have embolic events and sort of weird malaise sort of symptomatology. Malignant lesions tend to occur more commonly on the right side of the heart and benign on the left, but there are, obviously exceptions to this. So myxomas by themselves make up about half of all benign cardiac masses. And then there's this laundry list of stuff that just popped up. And it kind of at first can seem a little overwhelming, but we'll go through it and see that it's really kind of not. It's pretty easy to figure these out. Atrial myxomas are the most common primary neoplasm, make up of, as we said, about half. And female to male, I've read 3-to-1 in several literature series, but I've read more recent data that suggests it may be a little closer to like 2-to-1. Maybe our imaging is getting better or something. Appearance-wise, it's a well-defined intracavitary mass, typically, usually most commonly in the left atrium, although like in our case, it can be in the right atrium, often attached at the fossa ovalis to the interatrial septum. And like I said, about 80 to 85% are left-sided, maybe 10 to 20% are right-sided, and a very small percentage will be sort of trapped in the fossa ovalis like this, and they're called biatrial by some people. Maybe 2 to 4% or something are in the ventricles, like you see here in this case, but that's uncommon. They typically have a narrow stalk, but not always. And like in this one, you have this big, broad attachment, and look at it nearly obstructing the mitral valve. And you can get what people call a tumor plop in diastole with these. You can even produce left atrial appendage enlargement, like almost mimicking mitral stenosis. And what these look like histologically is sort of like a little bag of Jello. And if you think of it that way, its signal characteristics become a lot more clear. It has a fibrous stalk for attachment usually, but then this kind of coating or, cap of Jello overlying it. Sometimes you have a little bit of thrombi, which is what they're showing coating this thing, but that's not the important part. Just like in this, you had that whole dark rim around the little enhancing stalk. That's the bag of Jello. And that's why it was bright on SSFP imaging, because it's a gelatinous tumor that is high in signal because of its high water content. On T2 images, it's going to be bright. Or Cine images, remembering that Cine images are a form of T2 imaging. Okay, so there it is on T1 and T2. ISO intense and bright, just like pretty much everything. Okay, so they're gelatinous. The differential really is mostly with thrombi. Here's a case of a thrombus. Remember, it's isointense to muscle on that non-contrast image on the left, right? You give contrast, and now you can tell what it is, right? But that's our main differential, and it can, in all the cases that Chet and Shinoy and I looked at, some 900 cases or something, we weren't wrong too often, but when we were wrong, it was struggling between thrombus and myxoma was one of the more common differentials, particularly because myxomas, when they're small, may not be perceptibly brighter than muscle or more than isointense. But when they are, it's pretty apparent what you're dealing with. Notice the enhancement of the stalk. That's very common, where they are attached to the fossa ovalis or to whatever they're attached. And they have this heterogeneous appearance where the fibers, the gelatinous cap may not show much enhancement. Okay, I'm going to turn now to a second. I think most people consider this the second most common tumor, papillary fibroblastomas. They're rare tumors, probably the second most common. They most commonly originate from the valves, the atrioventricular or ventricular-atrial valves. And they kind of look, in a lot of people's opinions, sort of frond-like, like a sea anemone, which took me a little while to practice saying that. Anyway, there's small excrescences. Here's one that's on the aortic valve. A lot of times they're picked up as part of an embolic workup, and they're presumed to be the source of those emboli. And therefore, they're problematic when they're on the left side of the heart. A lot of times people advocate for their removal. They can be tough to see with MR on the valvular structures because they're often very small lesions. Here's one on the pulmonic valve. Here's one on the mitral valve, very tiny, can be very tough to see. But they're often surgically removed because of their potential for embolization. Here's a weird case we had where it was in the orifice of the atrial appendage. And you see on the image on the right, the enhancement with the red arrow pointing to it. That's kind of characteristic. These things don't enhance aggressively or early. You have to kind of wait maybe 15, 20 minutes to really get good enhancement that you're sure about. So delayed enhancement is probably the key to making the correct diagnosis here. They will enhance, but it usually may take a while, or at least in my experience, most of them enhance. Okay, so here are our intracavitary lesion differentials, the main one being myxoma versus thrombus, myxomas being brighter than muscle, thrombus being isointense. The other ones are more valvular lesions, that is vegetations and PFEs, and so they're usually not a big, diagnostic distinction. Usually the patient's clinical condition will allow you to differentiate those. And all of those are benign, right? Okay, so now we're going to move on to another case study, a lady with a questionable mass in the region of her interatrial septum. We see these on CT all the time. There's kind of a barbell sort of appearance to this area of abnormality, the interatrial septum. Here's a different case, similar sort of thing, but with a T1 image and then with T1 with fat suppression, and you see that it gets signal knockout with fat suppression. This is lipomatous hypertrophy of the interatrial septum. The only thing that's misleading about this is that these can actually kind of go up into the mediastinum or be contiguous with mediastinal fat and even kind of encroach on the SVC. So I think they get intermixed in case studies or in literature reviews with lipomas, true lipomas. But these are a little different. They're not an encapsulated neoplasm. They're benign overgrowth of normal fat cells. And although people talk about an occasional association with arrhythmias, in my experience, they're almost always incidental findings. They give you this characteristic barbell appearance where you spare the fossa ovalis, and the septum should be notably thick. A true lipoma is an encapsulated neoplasm. They can be fairly large because they're so malleable. They don't often press on things too much. In this case, the image from the literature is impinging on the right atrium, but a lot of them will just be, extend into the pericardium and be epicardial even and are not particularly aggressive lesions. They typically show a low attenuation mass on CT, but with MR, you can very specifically diagnose it using fat saturation techniques. And I think one of the main things I would make, here's the case that I put in here because it illustrates the difficulty in differentiating weird or atypical lipomatous hypertrophy from a true lipoma. I'm not sure it matters because you're not going to do anything with this anyway, but just, trying to make that distinction can be difficult. One key thing with both of those lesions, they do not enhance. Lipomas do not enhance. Okay. So you have two kind of fatty lesions, quote, tumors. I don't know if they're really tumors. Lipomas are, I guess. Okay. Now here's some pediatric cases. We're going to look at a 4-year-old with a questionable cardiac mass on echo. Indeed, we confirmed it on MR. It involves a lot of the left ventricular free wall, very large lesion. He does not have tuberous sclerosis, which is important, as we'll describe. And there it is on its delayed enhancement, all right? So it's quite bright, maybe with a kind of darker center. So the differential really in childhood is predominantly between rhabdomyoma and fibromas. They're tumors of childhood. A lot of people think they're actually probably hamartomas rather than true neoplasms, right? And they most often involve the septum and ventricular free walls, and both are recognized because they don't contract, right? So they sit there as these like small areas of non-contractile myocardium. Rhabdomyomas are probably the most common, and they are seen more often in children with tuberous sclerosis. You notice here the multiple, you see 2 lesions, which is fairly common. A lot of times they'll regress as childhood goes along. They may be more apparent in early childhood and regress as the children grow up. Here, this is an excellent paper from Rebecca Barucham up in Boston, who coordinated a multi-center study of childhood tumors because they're so uncommon. Nobody had a lot of experience with it. But again, let's just kind of look at this. So T1, it's ISO. This is a rhabdomyoma. T2, a little bit bright, right? First pass perfusion, not really enhancing much. And then this is really important on the delayed enhancement, or LGE, they're calling it the MDE, but the delayed enhancement sequence, it's iso-intense to muscle. And if you think about it, it's made up of rhabdomyocytes. So maybe that makes sense, right? So it's not bright, it's iso-intense, it's dark, it nulls with normal myocardium, right? Contrast that in a second here. We're going to talk about fibromas. Here's one that's involving the anterior right ventricular free wall and diastole and systole, second most common primary tumor, but they're seen frequently seen in a little bit older population. That is, maybe a third will escape into adulthood. I'm sorry, 20% will escape into adulthood, and the mean age is actually close to 13. They can be seen just like rhabdomyomas. They involve the ventricular septa and the free wall. I don't think those locations help much with the differentiation. But fibromas are almost always solitary. They're not multiple. They're seen not in kids with tuberous sclerosis, but rather in kids with Gorlin syndrome. And the one time that maybe T2 imaging helps is in adults, at least, or older children, where the tumor may actually be dark because of its fibrous nature. It's made up of fibrous tissue, and just like fibrous tissue elsewhere, it doesn't have a lot of free protons. It's dark on T2 imaging, kind of ISO on T1, but the early childhood fibromas, this is not true, as we'll talk about from Barucham's paper, but older kids and adults, they can be dark because they're largely collagenous lesions, right? Here it is on Barucham's paper, fibromas, ISO on T1, maybe a little bright, but T2 is kind of ISO or a little bit bright. It's not real bright, but it's not dark either. So in children, they're not dark because they're still cellular. They're not composed predominantly of collagen yet. But as they form collagen, they will look more like fibrous tissue. Very limited perfusion. And then the interesting thing is they enhance like crazy. So just think of them as a big fibrous scar. And just like scar takes up contrast, so does this thing. So, and they may have areas where they're incompletely diffused in the contrast. So they may have little dark areas internally, but they're typically bright. So that's a very important distinction. The other distinction is that the fibromas are seen in Gorlin syndrome, not tuberous sclerosis. So here's another case. Here are still frames from cine and delayed enhancement images in this right ventricular case. Here's one with a bright blood delayed enhancement where you can really see the interface with the blood pool. Okay. So the imaging characteristics of pediatric tumors are really, pretty straightforward. They can look identical. As you see, all this stuff is the same. What's different is the rhabdomyomas are iso-intense on delayed enhancement, and fibromas are very bright. So it's really quite easy, actually. Okay. Another case study. This is a 27-year-old man who had really, scary episodic hypertension and new onset of heart failure. Here's a T1 image on the left. T2 is bright there. As you kind of see, it's in the interatrial septum and extended into the wall of the right atrium. T1 pre-contrast and post-contrast, the thing really enhanced. And then here's an actual angiogram. And that is a vascular tumor. He did not have a history of malignancy, so that's sort of interesting, right? That's a really vascular lesion. So it's only a couple of benign hypervascular lesions. Most hypervascular lesions are malignant, but the two benign ones are paraganglioma, or some people used to call it PHEO, and hemangioma. Those are the only things that are benign that are hypervascular, right? Paraganglioma is what we were just looking at, and they're rare tumors. Typically, people say they're fewer than 80. I think there must be more than that by now because they keep getting reported. And the mean age is in the 30s and 40s. They typically present with, many of these are functional, and therefore they present with hypertensions and signs of catecholamine excess. And they're typically seen where you would see paraganglioma anyway, along the margins of the left atrium, the left atrial roof, interatrial septum. And they can be bright on cine images. They can have really bright T2 values, light bulb bright, people call it, because they're neuroendocrine tumors, right? And they typically demonstrate intense enhancement. Here's another case from our experience. You see it on pre-contrast cine images, T1, it's bright on T2, and then you give contrast, and even in early first pass perfusion, as well as late first pass perfusion, this thing really lit up, and then it's enhancing on the late gadolinium enhanced images. So that's a classic paraganglioma, light bulb bright on T2 images. Hemangiomas and lymphangiomas are, tumors of endothelial structures, and basically the main difference is whether they're filled with blood, in which case they're hemangiomas, or filled with lymph, in which case they're lymphangiomas. And they're typically more epicardial lesions. They can be in the wall as well, but they're often external or on the margins of the heart, and they can be kind of bright. The hemangiomas can be a little bright. This is something that's not, in my experience, I haven't seen this reported in the literature, but you see this STIR image, this T2 weighted STIR image. You see these little septations in this hemangioma. That I've seen that in several of them, and it's really characteristic. I don't see it in anything else, and you see it similarly, but not as well depicted on the cine images. If you see something that looks like that, I'd be very careful about biopsying it. Be really prepared for it to bleed like stink. This is from Barucham's paper. This is another case where it's ISO, maybe a little bit brighter on T1, very, bright on T2. Interestingly, hemangiomas in her experience, just like in ours, were hypervascular and perfused, and then had abnormal enhancement on post-gadolinium enhanced images. So this is the same experience we had. Here's a case where you have T2 with these little septations in it. First pass perfusion, in this case, early didn't show up so much, but as time went by, it progressively accumulated contrast. Okay, here's one in the wall. You can kind of see, again, early first pass, it's a little more sluggish than the theo or the paraganglioma in terms of its appearance. Lymphangiomas, I had to get this case from the literature. It just looks like a big low attenuation cystic lesion on the outside of the heart. They're pretty rare. Okay, so these are endothelial tumors, if you will. So just to go back, benign cardiac masses, remember that myxomas make up maybe about half of all benign tumors, have a fairly characteristic location and attachment. Lipomas and LHIS have fat signal intensity. You're not going to confuse them. Rhabdomomas and fibromas are childhood intramural tumors. Again, pretty characteristic. You're not going to confuse them. And then you have two hypervascular intramural tumors that really have to be considered more when you're considering possible, malignant neoplasm, right? Because, but the nice thing is they're well bounded. They're not invasive as those malignant lesions tend to be. So that's kind of the key in figuring them out. So the benign lesions tend to be smaller, more well-defined, more likely intracavitary, and don't show as aggressive enhancement on perfusion imaging as other tumors that we'll talk about. Okay, we're going to move on to another case, a 58-year-old lady with a mobile right atrial mass on echo and rule out myxoma. And you can kind of see how, this could have been a confusing echo appearance. It's kind of prolapsing through the tricuspid valve, a component is, and you have another intracavitary component. But what's really apparent is how aggressive this lesion looks as it involves the right atrial wall. So this is a kind of a scary lesion, right? Here's another case of the same disorder in a different patient. Poorly defined boundaries, enhances aggressively on perfusion imaging, as you can see there. Heterogeneous on delayed enhancement imaging with a short inversion time. They may have some coding thrombus on long inversion time images. And so just to review its characteristics, it's intramural, has poorly defined boundaries, it's bulky and large, and it enhances on perfusion imaging. Very heterogeneous on delayed enhancement MR. So these are not benign features, right? These are descriptions of a malignant process. So what primary cardiac malignancy preferentially involves the right atrium? Osteosarc, angiosarc, undifferentiated sarcoma, or do they all have a right atrial predominance? I thought I had a question. I gave the answer away. Sorry. Yes, it is the angiosarcomas most commonly on the right. But anyway, just to go back, about 25% of primary cardiac masses are malignant, and almost all are some form of sarcoma, right? So you have this laundry list of potential options, but really angiosarcoma, much like myxoma makes up a predominance of the benign lesions, angiosarcs make up the predominance, maybe 40 to 50% of all malignant primary cardiac tumors. Middle-aged men, the most common population, but the age is variable and it's only a slight male predominance. They tend to occur, angiosarcomas tend to occur in the right atrium, often involve the pericardium. They can present with signs of tamponade. And they say in the literature the prognosis is poor with a survival of 6 months, but we have cases of people, we have 2 people we're following that are almost 5 years out. It's crazy. That is, they are far outliers, but they had good surgery, I think, at the beginning, may have been the saving grace. Here you see cases with pulmonary Mets in this patient with the right atrial tumor. They can be bright on T1 because of areas of internal hemorrhage. I don't want you to worry about this. The only reason I put this slide up is because I'm going to put these little arrows up and show that outside of the angiosarcoma, the malignant fibrous histiocytoma, the undifferentiated sarcomas, all the others have a left atrial predominance. The only one that has a real strong right atrial predominance is the angiosarcoma. So if you see an aggressive looking lesion there, it's probably angiosarcoma. And the other ones are not distinguishable. I mean, here's a left atrial osteosarcoma. There's no way to say this isn't a fibrosarcoma or, any other sort of sarcoma, but it's a bad tumor. Lymphoma is the next most common thing after sarcomas, and it's almost always an aggressive B-cell lymphoma, typically seen in immunocompromised patients, often accompanied by large pericardial effusion. And interestingly, it has this tendency to involve the right heart and the RV free wall and to encase the right coronary artery. I don't know why, But if you see a tumor that's not displacing it, or just, a huge tumor like the angiosarcs that kind of tend to just engulf everything. But when you see it selectively encase the right atrial, or extend into the AB groove, think of lymphoma. That's a very characteristic sort of thing. Sarcomas and lymphomas, I don't think, are capable of being distinguished, really. They're all hypervascular. But, the point being is that malignant tumors are infiltrating, and they have poorly defined boundaries, and they're bulky tumors, usually hypervascular, and give you heterogeneous enhancement, and much more likely to have pericardial effusion. So you can usually be pretty confident of what you're looking at. Okay, here's another interesting case. 37-year-old male known to have colon cancer. He had a central line in, and they found something on echo, suspected right ventricular lesion. And so they wanted to rule out thrombus. And if you look at that, it's isointense to muscle, and you might think, okay, yeah, maybe that's thrombus. So you wouldn't really be able to figure that out. But then if you do delayed enhancement, wait a minute, it's enhancing. So it's not a thrombus, right? So this is going to turn out to be a metastatic lesion, which are 20 to 40 times more common than primary tumors, and obviously are associated with a poor prognosis. Often are terminal developments in people who are known to have metastatic malignancy. If you go to all autopsies of cancer patients, 10 to 12% will have cardiac involvement. But it's almost always, if it is recognized in life, it's almost always a near terminal event. So the lung is the most common primary site. After that, leukemia, lymphoma, or non-solid malignancies make up the next biggest group, and then breast and esophagus. Clinical presentation, they're often not recognized until pretty late. Probably the most common presentation is pericardial effusion, because of malignant effusion. And arrhythmias if you have a patient with a known malignancy who develops an arrhythmia, you should be suspicious of a new myocardial met, like you see in this patient with a T-cell lymphoma who developed a new bundle branch block. And you can see the abnormal enhancement there in the septum, which was confirmed on PET-CT and subsequently with biopsy. So consider myocardial infiltration in that setting. So how do they get there? Well, they can directly invade. They can retrograde extend from lymphatics. They can spread via hematogenous spread. Or like in this case, you can have transvenous extension up the cava. Direct invasion is commonly seen with mediastinal tumors like thymoma and lung cancer. Retrograde lymphatic is almost always seen with lymphoma, where the mediastinal lymph nodes get involved, and then it kind of grows backward into the pericardium. Hematogenous seeding is very common with hematogenously spread mets, like a renal cell carcinoma, like you see here. And notice the abnormal enhancement. And then transvenous things we see typically, if it's in the right heart, it's coming up from the cava, and it's usually either renal cell, hepatocellular, or adrenal carcinoma is the most likely. If it's coming in from the lungs, it's almost always a lung cancer, coming into the left atrium. Very few metastatic lesions really are characterizable. The only one that can be characterized with any confidence is melanoma, because they'll have a high T1 signal on pre-contrast imaging. But they usually will show abnormal enhancement. Here's that same melanoma case on post-contrast imaging. You see that heterogeneous enhancement, very characteristic. Okay, just how do we figure mets out from primary malignancies? You really can't most times. I mean, visually they look the same. I think mets usually have a history of known malignancy, but here's a case just to illustrate this point of that angiosarc we looked at earlier. Here's a metastatic melanoma. I mean, it's a little bigger, but other than that, it's kind of similar looking. I wouldn't be able to tell them apart. But look at the melanoma case, has lesions also in the liver and so forth. So, you're dealing with a metastatic process probably. Mets are more often multiple than primary tumors, are rarely multiple. But honestly, any of them can look alike. And I don't want to the only things I would pay attention to, they all can be hypervascular. The main distinguishing feature is the history of malignancy is what sets mets apart. Okay, so how well does MR work for all this stuff? Early series way back in 2003 looked at 55 patients and, had good areas under the curve. They were pretty accurate in terms of detecting malignancy versus benign, right? More recent study of 59 patients also did very well, 96% accuracy. They're very good. We did a study with like 900 patients, as I mentioned. And the nice thing was because it took us so long to get it done, we had a long follow-up period. And what was sort of interesting was our no mass pseudomass is made up about 40% of cases. Thrombi were another, and we excluded known thrombi. These are unknown thrombi or undetected thrombi, made up a small percentage, and as did benign tumors and malignancy. And our accuracy was quite good. What we noticed was that malignant tumors, as you'd expect, had a high mortality rate. This is the overall incidence of death, as you see up there at the top. Malignancy in the orange line had whether primary or malignant, had bad outcomes, not surprising. Benign tumors, pretty good outcomes, and pseudomasses. The interesting thing is that green line is thrombi, which had a sort of intermediate prognosis, and that's because they probably are associated with ischemic heart disease and so forth. So the other thing was that if MR says you're negative, that was correct in like 384 out of 385 patients, even though about 32% of our patients had a history of malignancy. So even in a cancer population, we were able to exclude tumors. So that's probably one of the greatest values of MR. So at any rate, okay, now we know how to find the lesion and we know how to characterize it. The key points to remember that METs are way more common than primary tumors. Of the primary tumors, benign are way more common than malignant for primary cardiac tumors. And atrial myxomas make up probably about half. Sarcomas are most commonly make up the malignant primary tumors, and angiosarc is the most common. So what MR can do for us is localize the tumors. It can evaluate the impact on cardiac function. It can do some tissue characterization just based on cine images. You can get T1 and T2 images if you need to. Delayed enhancement images can also detect and characterize lesions. But I think probably the best single sequence to evaluate tumors is the perfusion sequence, which is very helpful. I've put these in. I don't know whether we give you all handouts. When I give this lecture at some places, I'll do that, and then you have all these, but it's a lot to look at, just like this, but just the intramural. I think it's very helpful to distinguish the lesions by location. In other words, here's your intracavitary differential. Here's your intramural differential for children and in adults, right? Notice that METs is the most common thing in adults, and then you have these other things, right? And then here's your epicardial lesions and pericardial lesions. Again, METs being predominant. Okay. Shortness of breath. I just throw this in. This is a little bit different, and I should maybe include this, but anyway, is this a PE? People saw this at first and thought it was a pulmonary embolism, but if you look at it a little harder, it looks like maybe the wall's involved. Here's an MR of this, and you see this, filling defect in the main PA. And here it is. Here's another case of a similar lesion, PA sarcoma that I got from Duke. These are PA sarcomas. They're not to be confused with pulmonary emboli, and they're the most common primary malignancy of the pulmonary arteries, commonly mistaken. Male and female rates are about the same, and they don't have a great prognosis. I just thought I would show that real quickly. And we're about to close off here. I'll go through these quickly and try and leave time for questions. Regarding thrombi, which is false. They adhere to sites of infarction. They're common in people with dilated, equally common, blah, blah, blah. This is false. They're way more common in ischemic cardiomyopathy patients than non-ischemic. Most common cardiac mass, this is from the beginning slide, is thrombus. That was the eustachian valve. METs are 20 to 40 times more common than primary tumors. Most common primary cardiac neoplasm is the myxoma. Regarding thrombus, you really do. This is a false statement. They do not require contrast. This is a false statement. They do require contrast. Okay, and that's it. So, any questions? I'm happy to take. And I don't know. Should I look maybe at the chat? Oh, the text things. Yeah. Okay. Thanks, Corey. But any questions anybody has? I'm game.
Hey, this is Ed Soy. John, wonderful lecture. I've encountered occasionally myocarditis, MRI for myocarditis. I had an interesting case. Myocarditis can have really chaotic movement of the vegetations. And the MRI, TEE captured it brilliantly, but the MRI, look, I love MRI, but MRI completely missed it. You couldn't see it because of the heated imaging. Right. How often are you seeing that there is a myocarditis, and I know it's kind of a spitball thing, but because of the way they move and the gated imaging necessity for
Sure.
CNA images.
Sure. Yeah. And so I think we're talking more about endocarditis, right? But I get what you're saying, and you're exactly right. Yeah. No, I figured. So that's a really good point. I'm really glad you brought that up, because it illustrates the fact that if you have, the way MR usually works is that you're building an image up from multiple repetitive heartbeats. And so the presumption is that at any given phase of the cardiac cycle, that, let's say, the anterior mitral valve leaflet will be in roughly the same place at any given point in the ECG cycle. If that is not true, if you have chaotic movement, then all bets are off. You may or may not see really even huge vegetations. If they move chaotically, in other words, by chaotically, I mean they do not reproducibly line up at the same place at the same point in the ECG cycle from beat to beat. If they move around and they're not in there, it's just like, the old pictures where you see people walking through a photograph in the old days, and they're just this streak that you couldn't make them out as people. They or even be invisible. You won't see them. You're quite right, Ed. You're quite right. And yes, that's a famous limitation, and I'm glad you brought that up. I should mention that when I talk about vegetation. Small ones can be missed on that basis. Yeah.
Thank you, Dr. Grizzard.
Yeah, I'm sorry. I'll just add one other thing. Because they're not built up over multiple beats, a real-time image probably has a better chance of showing them, because it'll actually show that frame by frame thing. You're not segmenting it. You're not obtaining parts of each, image. You're getting it all at once. Sorry to interrupt.
No, thank you very much, Dr. Grizzard. It's a great lecture. I'm just like following up on Ed's question, and I think you just answered it. Any sequences that you recommend in like evaluating small valvular regions or fibroelastomas, or any change in the parameters of the setting that you recommend to try to tease it out?
Yeah, so I think for tiny lesions on the valves, we often do those what we call small field of view high resolution images, where you put a lot of phase oversampling so you don't wrap into the image. And because you're using a much smaller field of view, you don't need the matrix to be that high. In other words, if ordinarily you're looking at a 380 centimeter field of view with a 256 matrix, you end up with a pixel size of 1.5. But if you're cutting that field of view down to 200, and you're doing, a 192 matrix, it's basically a 1 millimeter pixel size. You see what I mean? So your matrix can actually be smaller. My advice would be to take down your field of view. You don't have to. You can take down the matrix, imaging matrix, which will save you a little bit of time, because you're going to need that time to do oversampling in the phase sense. And that will often help in terms of imaging small structures on the valves. The other thing you can do to get better temporal resolution, Mo, is to cut down the number of segments. And GE terminology, it's cut down the views per segment, but basically get fewer lines of K-space with each beat. That way, your temporal resolution will be, instead of 40 to 45 milliseconds, maybe 30 milliseconds. So it'll be better shutter speed, so to speak. But the patient has to be able to hold their breath. It'll be a longer breath hold, okay? And then lastly, if all else fails, try a single shot or real-time, imaging, where you're not doing segmented imaging or building it up out of multiple beats. You're just imaging it in real time, okay?
Thank you very much.
Sure.
Dr. Grizzard, thanks again for this wonderful talk. I wondered, when you were doing the review of 900 plus cases with Chet and Shenoy, did you all see what was clinically read on those cases? Or I guess what I'm asking is, what are the most common pitfalls that you've seen, masses that are mischaracterized by clinical readers, not the expert reviewers like you and Chet? Any advice on how to avoid those misclassifications?
Well, I think we actually went back and looked at all the original reads, and honestly, I had read all of ours at that time. There was nobody else reading MR for most of it, at any rate. And then there was at Minnesota, Chetton had read those, so it's a little bit of a skewed a reading group. But to get to your point, the sources of confusion were mainly twofold. I mean, anybody can miss anything, don't get me wrong, but in terms of systematic errors, the thrombus versus myxoma thing was not always perfect. The idea that you could reliably say the myxomas were brighter than thrombi, sometimes it was tough. Obviously you can anticoagulate them and, sort of that way, but sometimes in terms of just diagnosing it correctly, if we were wrong, one instance was we would mistake thrombi for myxomas and vice versa. That would be one source of error. The other one that reliably we mistook was we didn't realize that hypervascular lesions could be benign. So those paragangliomas and hemangiomas that were hypervascular, we called them, I think almost every time we called those malignant. Luckily, there weren't that many, so we didn't get that many wrong. But those are the errors that were consistent.
Great. Thanks so much.
Yeah.
All right, well, I think we've hit the end of the hour, so we'll go ahead and close the session. Thanks again, Dr. Grizzard. And Shannon, maybe if you don't mind putting up the CME slide just for a couple minutes if people want to claim it at the end. Just to plug, next week we're going to do a case sharing day. So if anybody has any interesting cases, feel free to reach out to me or Shannon, and we'll try to get you on the schedule. Thanks again, everybody.